Hello, happy Sunday. Hope you've had a good and productive day today. Thank you for so many questions. I've had a huge number of questions and I have read them all. I'm not sure I'll be able to answer all of them. As I've said before, I'm not wearing my glasses, so I can't read any of your questions or comments, and that's partly because I don't want to get too distracted with what I'm wanting to tell you today. I do have one of my colleagues who's on who will look at some of the questions and direct you a little bit if that's helpful. So today, because it's a new year, Happy New Year to you all, I just really wanted to talk and continue from my conversation last time. As some of you might remember, if you listened to me last time, just before the new year, I was talking about hormones, what they do in our body, how important they are, and specifically talking about our sex hormones. So estradiol, progesterone and testosterone, that, as you might remember, are produced in our ovaries, but they're also produced in our brains, and they're biologically active hormones throughout our body. So hopefully the next question will be, well, what about these hormones when we don't produce them? How do we get them back? And this is what I'm going to spend the next half hour talking about, is natural hormones. How do we get them back? So most of you, I'm sure, if you know who I am, have been thinking about the menopause, which is a very archaic description, actually, I think, when we define the menopause as a year since the last period. It's defining women as their periods. Many of us don't have periods or don't want to be defined as whether we bleed or not. And actually, I find as a physician really hard to say to a woman, oh, I can't diagnose you yet because you haven't had a period. It's only been 11 months or 10 months. But that's how the powers that be have decided the menopause is defined, by a year since the last period. Or some people will talk about it being loss of fertility. But we do know younger women who have an early menopause at a younger age can still be fertile. And actually, as a woman, I don't want to be defined as my periods or fertility. And as I've said before, what happens is our ovaries don't work as well. Either they've been damaged, we've been removed, or just because we're older, we run out of eggs. And so the hormones associated with egg production, estradiol, progesterone, testosterone, decline. So that's what happens in the menopause. But once our hormone levels decline, they are low forever. There are a huge number of symptoms that we can get when we're menopausal. But before the menopause is this perimenopause. Peri just means around the time of. So our hormone levels start to decline sometimes 10 years or so before we become menopausal. And often we don't realise, because periods can be heavier, they can be closer together, and we can get these myriad of symptoms. And people often think, oh, it's because I'm stressed, I'm not sleeping well because I've got young children, I've got a lot going on, that's why I'm getting migraines, I'm getting older, so that's why I'm getting joint pains, not piecing it all together, thinking about hormones. And so there is a symptom checker, actually, that's on the Balance Menopause website, and it's on the free Balance app as well. Now, this isn't all the symptoms of the perimenopause or menopause. It's not an exhaustive list, but it will give you an idea, and it actually grades whether you're having none at all, whether you're having a little, quite a bit, or extremely. With a column for comment as well. And we ask everybody who comes to the Newson Health Clinic to fill one of these out. Because it can be really useful to see how symptoms are, which are the worst symptoms for that individual, and also when people are on treatment, hopefully, how their symptoms improve. So that's something to look at. With the perimenopause and menopause, there's no diagnostic test. You can't come to us as a clinician and we do a blood test or a saliva test or a urine test, and we can say to you, yes, you're definitely menopausal, yes, you're definitely perimenopausal, or what I've heard other people say, oh, you're along the transition process, or you're nearly through the menopause. It doesn't make sense. Our hormone levels change, and actually our hormone levels that we do in the blood aren't equivalent to the hormone levels in the tissues. So for example, if someone has really low mood and anxiety and we think it's related to their hormones, I don't know what their level of hormones is going on in their brains. All I can do is a blood test, which isn't going to be representative necessarily of what else is going on in their body. So it's usually a clinical diagnosis. It's a diagnosis from asking questions. We do clinical diagnoses a lot in medicine. For example, if we think someone's got depression, if we think they've got bipolar, even if we think they might have a chest infection, as a GP, we don't often do tests. Obviously, sometimes we need to examine people as well, but the most of the diagnosis is in the history taking, and also asking patients, what do you think is causing your symptoms? And often women know themselves that it can be related to their hormones. So the most important thing, I think, is for women to understand what's going on. So when the time comes and you think you're perimenopausal or menopausal, you are probably right. So make sure you have someone who listens to you and understands hormones. Far too often I speak to or listen to women who have been fobbed off by people who've been said, it can't be your hormones because you're not having hot flushes, or it can't be your hormones because you're only 32, it can't be your hormones because you're 66, it can't be your hormones because XYZ. Actually, if you think it might be, then you're probably right. So that's really important. Now, when we think about our hormones, I'm just going to show you a little picture because I think this is really interesting actually. I have spoken this about before. This is a picture of what our hormone levels do throughout our monthly cycle when we're having periods. And you'll see here, I know it's hard to read, but you'll see that we've got different hormones. We've got our estrogen peaks when we produce an egg in ovulation, and then later on the green is our progesterone. It goes up and then it goes down. And if you look right at the end, there's no hormones. Everything's really flat. And this is when we have our period. And this is the time when we don't have hormones usually, or the hormone levels are low. And that's often when we feel rubbish before a period, or certainly I used to when I was younger. You'd have a couple of days where you just feel very flat, you couldn't be bothered to do anything, often have sugar cravings, maybe have headaches, just feel a bit rubbish. And then your period would come and you'd feel a lot better. And for some women it can be even worse. People can have PMS or PMDD, and that's a bit of a flavour for what the menopause is often like. Now this graph is actually out of scale, because if I look at this picture, actually, it's the progesterone is a lot higher. The scale is different. So this is actually what the graph looks like down here. There's a little peak of estrogen and a massive peak of progesterone. So this big drop isn't just about estrogen, it's about progesterone as well. So some people miss estrogen, some people miss progesterone, some people miss testosterone, and some people it's all three. And this is where it can be quite confusing when we talk about HRT, because HRT, or in some countries it's MHT. So HRT is hormone replacement therapy, MHT is menopause hormonal treatment. But actually, either of those terms I think are wrong. It's just natural hormones that we're giving back to people, because it's not always about the menopause. We can start our hormones in the perimenopause when our hormone levels are fluctuating, because they're fluctuating, but generally they're declining, and that's what's causing the symptoms as well as this fluctuation. So we don't know always whether it's the absolute level or the fluctuation that's triggering the symptoms. And some of the brain symptoms, the anxiety, the worrying, the rumination, the OCD that might come back, the low mood, the intrusive thoughts, it probably is related to fluctuating hormone levels of all three of our hormones, so estrogen, progesterone and testosterone. And testosterone, as I've said before, is another really important hormone that just declines as we get older. So you might be thinking, well, that's great, but how do I know which hormone I want, and how do I know which hormone to start with? Well, often we don't know, and that's where we work really closely with patients. Estrogen is always thought of traditionally to be the most important hormone, and HRT, or hormone replacement, or just natural hormones, we usually include estrogen. There are some women, however, who find that they've got enough estrogen in their body, they're having regular periods, you give them some estrogen and they might feel worse. And those women might be more progesterone intolerant or testosterone intolerant. Now, from the symptom list, it's impossible to say which hormone you're more you're missing out on more, because actually all the symptoms can be due to all three of the hormones. As a general a sort of very generalisation, symptoms of testosterone deficiency are often low mood, reduced concentration, low stamina, not wanting to exercise as well, just feeling quite flat, feeling quite joyless. That's often related to testosterone. But I've seen a lot of women who have low estrogen, and I give them estrogen and those symptoms improve as well. But often, because our hormones all work very closely together, it's often the combination of hormones that makes the biggest difference. So even if someone's more estrogen deficient than testosterone deficient, they might only feel 60% better on estrogen and may not feel completely better until you've added in the testosterone as well. And this is where it's important when you start HRT to see someone who really understands. Now, in the perimenopause, our hormone levels are fluctuating a lot, and it can be quite hard to find the right dose and type of HRT because, as you can imagine, what works initially might not work after a few weeks or months when the chaos continues or levels decline. So sometimes we see people, and that's often related to the hormones not being absorbed properly through the body, or it's due to this fluctuation of hormones that occurs. And so we review people quite frequently initially, usually after sort of starting HRT. We usually review people after about 3 months and see how they're getting on and look at the symptoms to see whether the dose or type of HRT needs changing. And in the perimenopause, often people do. But also, if I just show you this graph as well, in the perimenopause, people are still usually having periods. So they're still producing their own hormones, and they still might be producing hormones like this. So sometimes people say, do you know what, I feel great, but just before my period, I still feel awful. And sometimes those people then can increase their estrogen dose just on the few days where they feel bad, because you're just trying to mimic what's going on, but you're trying to improve this dip at the end. And so sometimes people, especially if they're on the gel, it's more flexible, can use a couple of pumps or 1 or 2 pumps before their period, in addition to having maybe a patch or gel throughout the month as well. So we usually give estrogen every single day, but there is some fluctuation. Now, some people, when they have, it's not quite as smooth as this, they're up, down chaos, it can really trigger, like I say, a lot of symptoms. And if you add in a lower dose of estrogen, you're still going to get this up, down fluctuation. So sometimes in the perimenopause, we give higher doses of estrogen to try and suppress that hormonal variation. And that can work really well, especially for people who have migraines, for example, because if you have migraines, any change in level, especially a quick change, can trigger migraines. And so there are some people who are perimenopausal who we might give higher doses to suppress their own endogenous hormones. And this is where it's very individualized. And then with time, people might need a higher dose as their own hormone levels decline. Or if we've given a higher dose in the perimenopause, once all this variation stops and their own hormones stop being produced, we might find we can reduce the dose. So it's just working out what's right. Now, with the dosing, it's not just about the dosing, it's about the absorption, and I've mentioned that many times before as well. So what one of my friends might absorb or one of my patients might absorb is going to be very different to me. I know my patches don't stick on very well. They crinkle quite a lot, and so I use more than one patch, but my level, you can do estradiol levels, has never been that high. I've got some patients who are on a lot lower dose of just a small dose of patch, and their level is quite good. Now, estradiol levels, as I've said before, can be quite unreliable, as you can imagine, especially in the perimenopause where our hormone levels fluctuate so much. But they're a useful guide when people are on HRT. So if I'm seeing someone who's still having some symptoms that I think are due to their perimenopause or menopause, and they're on maybe a patch, I do their estradiol level and it's low, it shows that I can safely increase the dose, and it's probably because they're not absorbing well. So they can be useful. We don't usually do progesterone levels because we want to know what's going on in the tissues, and a blood is not a good representation of what's going on in the tissues. And we do testosterone levels, just really making sure that women's testosterone levels are in the normal physiological female range, and we usually do those every year. So I wanted to show you some other things as well. So some of you might have seen these. We've got so Sarah Glynn, who's an academic doctor working with us, who's got the brain the size of a planet. She's an absolute genius, but she's written these and we've had them drawn up. So this is understanding the benefits of HRT, because there are benefits despite what we've been told for decades. And the pink ones are understanding the risks. Now, you might see that the benefits actually is on 2 pages with some writing as well. And the risks actually is just on 1.5 pages. So that's telling you something already, that there are more benefits than risks with HRT. Now, this is about body identical HRT. So this is the natural hormones. These hormones are exactly the same as the hormones we produce when we're younger. They haven't been chemically modified in any way. The synthetic hormones have. So synthetic hormones are those that are in the contraceptive pills, they're those in the combination tablet HRT, and actually even the combination patches. The estrogen is body identical, but the progesterone bit is not, it's synthetic. And as I've said before, the synthetic hormones do have only small, but they do have more risks than the body identical hormones. So if we look at understanding the major long-term benefits means beyond symptoms. Of course, when we give the right dose and type of HRT, it will melt away the symptoms that are associated with the hormonal deficiency. So our aim, certainly my aim as a clinician, is to enable women to have the right dose and type so their symptoms melt away. And that's really important, but it can take a little while for symptoms to improve because, as I've already said, you've got the short-term effects that are going on in the cell every day and the longer-term genomic effects, so they can affect the way our genes work as well. So we have to be patient when we start HRT or change the dose. So the number one benefit, actually, it says here, is all-cause mortality. So mortality is death, and all-cause means from any reason. So actually, women who start HRT in the perimenopause or menopause, so that's within 10 years of their menopause, usually under the age of 59, there's actually, if people are going to die anyway, I hate to tell you, people die regardless of whether they take HRT. So if you've got 7 deaths just because of anything else other than HRT, you've got 2 fewer for those women who take HRT. And so that's really important, actually. And that's 2 if they take the synthetic type of HRT. If they take the body identical hormones, it's even more, actually. It's 2.5 out of 7 women. So if you extrapolate to thousands of women, that's a huge amount of lives are being saved by HRT. Some of you might question that, thinking, well, actually, we've been told for years that HRT is dangerous. No, if you look at all-cause mortality, death from all causes, women who take any type of HRT, there's a lower cause of mortality. And women who take body identical HRT, there's even a lower cause of death from any reason. That's really important that we know that, actually. And then some of you might say, well, what about older women? I'm in my 60s. Is it too late to start taking HRT? Absolutely not. No one is too old to start considering HRT. And we do know from the studies that there doesn't seem to be a reduction in mortality if people have the older types of HRT. But actually, if they're given body identical estrogen, which is the estrogen as the gel or the patch, with a progesterone, more than 10 years of after the menopause, you'll see there's a lot of white here, which means there's a reduction. So there does seem to be a reduction in death for women who start taking HRT when they're menopausal from all causes. Now, as I've said before, most women die from heart disease and dementia. globally and also in the UK as well. Now, we know that the earlier we start taking HRT, the better. So that means we don't have to wait till we're menopausal. We don't have to wait till we're a certain age. Someone asked me the question, could I start HRT? Might it be too early? Well, no, not really. If you're getting some symptoms, it's suggesting that you might have some hormonal changes. And often we give a therapeutic trial, which means that we just try HRT for a few months. I've had some patients who I've started HRT on who I thought been perimenopausal. They feel better, but then after a while they said, oh, actually, I feel so great, I've just really reduced my dose. And what's probably happened is their ovaries have started working again and they don't need as much. And then 6 or 12 months later, they said, oh no, I've started a higher dose again because I can feel my symptoms coming back. And that's just what happens. Every day can be quite different. So the next part on here is coronary heart disease, and so this is heart attacks, so women who start HRT within 10 years of their menopause, you'll see there's half of this is in white and half is in the darker green. So it actually reduces incidence of heart disease by around 50%. That's huge. Now, we have written here that statins don't prevent coronary heart disease or reduce mortality in women when they're used for primary prevention. So statins, which lower cholesterol, have not been shown to be beneficial in a statistically significant way for women to reduce the onset of cardiovascular disease. That's different for secondary prevention, which basically means if you've had a heart attack, then there will be some benefit from statins. But if you haven't and your cholesterol's raised, you don't need to rush for a statin actually. You're better off getting some HRT. And we also know, because of the metabolic changes that occur in the menopause, that women's cholesterol reduces when they're on body identical hormones as well. So if you are having high cholesterol and you've been advised to go on a statin, usually, and this is a generalisation, I can't give individualised advice, but usually we recommend to start body identical hormones and we will watch the cholesterol reduce and then see. And if someone still needs a statin, of course they can have a statin as well as body identical hormones. In older women, again, with synthetic hormones, there's not likely to be a benefit. And that's really because of the synthetic progestogens. We know the synthetic progestogens do have a small risk of coronary heart disease. And we know that, that they can actually negate the cardiovascular protective effects of estradiol. But if we give body identical hormones, we haven't got really good robust studies. But the studies we do have say, you'll see there's a reduction, you see the white here, there's a reduction in cardiovascular risk in women who start HRT when they're older, which is really reassuring. The next part here is diabetes. So this is type 2 diabetes, and we know that the menopause is a cardiometabolic problem. There's an increased incidence of type 2 diabetes as we become menopausal if we don't take HRT. Now, if we take HRT, then there is a reduction. You'll see there's a small reduction in people developing type 2 diabetes, and it's a massive reduction actually in people who take body identical hormones. Now, how many people who run diabetes clinics will know about safe prescribing of HRT? Sadly, not enough. Now, I'm sure a lot of you heard me talk about osteoporosis before. Osteoporosis affects around 1 in 2 women over the age of 50, and around 1 in 3 women over the age of 50 are reported to have had an osteoporotic hip fracture. It's called a silent killer, and that's because it's never on the front page of the papers. People don't always know much about osteoporosis, but it's very important, and often we don't know we have it until we break a bone. We want to keep our bones strong, and we know that our hormones, estradiol, progesterone and testosterone, have a really beneficial effect in keeping our bones strong. Now, we know that if there are 50, on average, this is saying there's 15 fractures per 1,000 women each year, women between the ages of 50 and 59. Now, if you take HRT, that halves. You'll see half of them are white, because taking HRT will halve the risk of osteoporosis. And if people start HRT older, over the age of 60, then Clearly, more people will develop osteoporosis, that's no surprise, but there's still a risk reduction in taking hormones, which is really important to know. And some studies have shown even a low amount of estrogen for older women will be protective of their bones. What's also reassuring, and I have had some questions about it, is that body identical hormones are licensed, so HRT is licensed as a treatment for osteoporosis. So if you do have osteoporosis, you might need other treatment as well, but definitely think about taking HRT to help reduce and improve osteoporosis. And I've seen quite a few women whose osteoporosis is reversed with taking HRT. Now, the last part of this document, it talks about dementia, and actually since Lisa Mosconi's review that she's done that I've spoken about before, showing there's a 30% reduction risk with estrogen when started within 10 years of the menopause, so 30% reduction of dementia, we're going to change and have some figures, but this is some really good text to read, and basically showing that there is evidence that women who take HRT, especially in the perimenopause or within 10 years of their menopause, do, if it's body identical hormones, have a lower risk of dementia, which is really important. So moving on to the risks of HRT, actually for most of us there aren't risks. We've all been taught, haven't we, for years that there's a breast cancer risk, and this may be true for some types of HRT, but not for all. So if we look at this, if there are 23 cases of breast cancer in women aged 50 to 59 per 1,000 women over 5 years. So this is the background risk. So people will develop breast cancer. It's a very common cancer. It affects around 1 in 7 women. Most reasons we don't know why. We know that there are certain risk factors such as drinking alcohol, not exercising, being overweight, having a strong family history. So lots of reasons why people develop breast cancer. If someone has been taking a synthetic type of HRT with a synthetic progesterone, then they showed, this is the WHI study, which I've spoken about before, that there's an additional 4 cases. Very, very small increase, not statistically significant at all, actually. But this is what's really important. If women were only taking estrogen, so they'd had a hysterectomy, then there were 4 fewer cases. So there was a 23% reduction in developing breast cancer in women taking estrogen-only HRT. And then if women still have their womb and have estrogen and a natural progesterone, then you'll see it's exactly the same as above. But it's still got a background risk. So that means women on HRT, some of them will develop breast cancer, but the incidence will not be any higher than those not taking HRT, which obviously shows there's not an increased risk, which is really reassuring. Now, the rest on here talks about clot and stroke risk. So it says venous thromboembolic embolism, which basically is a long word for clot. And it's been divided into women between the ages of 50 and 59 and 60 and 69. And you'll see there is an increased risk of clot, but only with oral, so tablet estrogen with a synthetic progesterone. And I've mentioned the reasons for that before, and we've got a booklet about clot risk and hormones on the balance-menopause.com website. But if we have estrogen through the skin as a patch or gel with the natural progesterone, there's no increased risk of clot. And the risk factors for clot are similar to the risk factors for stroke. So this on the back talks about stroke risk. And actually, if women start HRT within 10 years of the menopause, you'll see this is the background stroke risk, doesn't increase at all. If people are older with the synthetic hormones, there is some small increase because of the way the synthetic progesterone works. But you'll see very reassuringly, actually, that there isn't an increase with body identical hormones. So actually, for most of us, there isn't a risk with taking HRT. There is just benefits. And that's really important that we know that. So then I've also got this, which I wanted to show you, which is actually, it's called HRT Easy Prescribing Guide. If you go onto the balance-menopause.com website, or just Google balance menopause easy HRT, you'll come up with this document. And I wrote it for healthcare professionals, and some of my colleagues have reviewed it and updated it for me. But basically, a lot of women actually look at this as well, and a lot of people I know have taken it to their doctors, and it's been really helpful actually for healthcare professionals. And it basically just goes how to prescribe HRT, what are the pros and cons of the different preparations. And in here there's a little table as well, which is the dose equivalents of various preparations. And I know some of you have asked, so if I'm on 2 pumps, what would be the patch equivalent, for example, which is usually 50 micrograms. But again, it depends on absorption. Some people absorb the gel a lot better than the patches. But that's quite useful as well. And then we've got about how to prescribe estrogen, progesterone, there's something about the Mirena coil here, and also about testosterone. And we've listed the common types of testosterone that we can prescribe in the UK. And there's a lot of references here as well, so people know that it's evidence-based. So this is the HRT Easy Prescribing Guide, and it is quite easy actually. The hardest thing is for women to be listened to and believed actually, and also get the right dose. Finally, I've been printing off a lot for you today, is this, which if you go to the newsonhealth.co.uk website, there's a little orange banner at the top, and it says why some people might need higher doses than others. And this is a document that we've written, and we've just entitled it, HRT is not a one-size-fits-all treatment. Of course it isn't, because we're all different. This is an explanation of why various doses are prescribed to different people. And so we've just really, this is mainly talking about estradiol doses, so doses of estrogen, and about why some people need more than others and some people need less than others, and about what we do about it, and some references are on here as well, just to reassure you that we use the most available references that we can. But a lot of it is common sense medicine actually, because if we have the way our skin absorbs, the way that our bodies metabolize the hormones as well, that we are all different, and doses often need to change with time. Most people actually don't get side effects with HRT. The commonest side effects are when people start HRT, and the commonest ones are bleeding. Some people get bloating, some people get breast tenderness. Now, the bloating and breast tenderness usually settle quite quickly. Bleeding really varies, and it can be quite troublesome initially. What we want to do is either, there are 2 ways of giving HRT with respect to periods, in that you can have it at what's called cyclical, where you have the estrogen all the time and the progesterone for 2 out of 4 weeks, and then people still have their periods. Or we give the progesterone all the time, or people have a Mirena coil and then they don't have periods. And a lot of people prefer that. If people want their periods, they can absolutely carry on, but they're not the natural periods. They're just a withdrawal of not having the progesterone. But whichever type of HRT you have, you might find that you have some irregular, it's quite chaotic bleeding initially, and it can sometimes be quite heavy. We don't usually rush and investigate if it occurs in the first 3 to 6 months, or if the dose or type of HRT has been changed. You can sort of let's see what happens for the first 3 months after a dose change. But if you are getting bleeding that's concerning you, that's heavy, that's persistent, then obviously go and talk to your doctor about that. And a lot of people just need a scan just to make sure there's not another cause for the bleeding. So if you have bleeding, it doesn't mean that you have to stop taking HRT at all. So women, in summary really, women, best time to start taking HRT is when you start to have symptoms, because none of us want to suffer, but also the health benefits are more the earlier we start HRT. But no one is too old. The oldest person who's come to the clinic to start HRT is actually 90. For her 90th birthday, she treated herself to a consultation with us, and she noticed quite an improvement fairly quickly. So no one is too old. You can start it whenever you think or want to, really. And there are different types, there are different doses. Most people, when they take HRT, take it forever because the benefits can outweigh the risks, but very few people stay on the same dose forever. It is adjusted, and people should be reviewed at least annually with a doctor who understands hormones so that the dose and type can be individualised for you. There are very few side effects. If you are getting side effects, it's usually because either that your body's getting used to it, or because you're not on the right dose or type of HRT. And that's really important, that you're not just stopped and said, oh no, it doesn't suit me. It's really important that you see someone who really understands what's going on. HRT is not a contraception unless you use the Mirena coil, so talk about contraception to your doctor. There's very few absolute contraindications for HRT. We're more cautious if people have had breast cancer that's estrogen receptor positive, and that's a very individualised consultation. But people who've had other types of cancer can still usually take HRT quite safely. Younger people, older people, people who've had migraines, people who've had heart disease can still usually take body identical hormones because that's all they are. They're just our natural hormones that we're giving back at the right dose and type for that individual. So I hope that's been useful. There's a lot of information. I'll go onto my stories this evening and I'll add links to what I've shown you today so that you can quickly find it. And so I will carry on doing the Instagram lives usually on a Sunday around 6 o'clock. Next week I think I'm going to focus on testosterone because there's been lots of questions about that, but I'll add this to the grid. If you want other topics over the next few weeks and months, then just please suggest them in the comment and I can just prioritise according to what you need. If it's been helpful, give me some feedback. If you want me to change the style and format, or if you don't want me to do it, just let me know. But I hope that's been helpful, and thanks so much for joining and listening, and take care and have a good week. Thank you.